Well, good morning. So this is a pre-recorded lecture. I'm going to emphasize a few points and cover some material from last week in Muscles 1, and then we'll go ahead and pre-record a lecture for Muscles 2. So go ahead and pull out your handout, get that ready for Muscles 1, and you can go ahead and pull out the PowerPoint to this point here. This is a real important slide. It tells a big story about how the muscles are layered and actually go in different directions. And also, right in the middle, you have what's called a linea alba. And the linea alba carries some vessels. It also helps connect the rectus abdominis in the middle and also connect these these muscles, these internal obliques, the external obliques, and the transverse abdominis, not necessarily in that order. As you can see, they're layered from the external oblique side here to the internal oblique side here. These down here is like putting your hands in your pockets as you come down. So if you remember from the outer layer, it's like putting your hands in your pockets. And then the internal oblique are actually, they start off at a different angle, but as they come in, they almost it's like putting on like an inside pocket. So you're like this, and then the transverse is just what it is. It's transverse, but they all meet in the center, forming the aponeurosis of the rectus sheath, right, and the linea alba, which is right in the center. The linea alba is referred to in Chinese medicine. It runs along the Ren meridian, right up through here. A lot of really important points right in here around the umbilicus. And this is where you're going to be working on with a lot of people with digestive issues, fertility issues. Right in through here is a lifesaver. All these points. And as you continue up the Ren line, it doesn't show it here, but you have your sternum where we use a point called Ren 17 and to open people up and help with issues around the heart. And it's a great the Ren meridian is a great meridian. But as you see, this aponeurosis of the external oblique pulls down. I'll show you guys a picture of it later, but it forms the inguinal canal that has is responsible for a lot of well, later on if it's defected, and you can have actually a defect while you're forming as an embryo. If things don't go right, people are susceptible to hernias, both indirect and direct hernias. And there's actually some vessels that run down, through here, and they actually, go into the testicles. And we're not going to get into embryology here, but understand that this area is very important for, for hernias, for indirect and uh, direct hernias. And there's a whole 2-hour lecture on that because it involves a lot of complicated areas where um, the testes when they actually drop into the scrotum, it brings everything with it. That include some of the tissues involved and the spermatic cord, and even part of these fascias of the internal and transverse abdominis sheaths, the fascias that surround them actually drop into the scrotum. So it's very interesting, very complicated area. But let's just talk about right now the external oblique. The external oblique is situated on the lateral and anterior parts of the abdomen. You're going to be tested on this. So I want you to understand these layers. And also, it is broad, thin, and irregularly quadrilateral. So it's quadrilateral. Its muscular portion occupying the side, right in here, and its aponeurosis, which is this white tendinous tissue, forms the anterior wall of the abdomen, right? Um, Females, the oblique is not so visible due to subcutaneous fat deposits and the small amount of muscle in that area. But um, in most females, it arises from 8 fleshy digitations from the external surfaces and inferior borders of the 5th to the 12th ribs. And I'll show you a picture. The next slide actually shows it, 5th to the 12th. I'll go ahead and show you real quickly. So right in here, you see your external obliques and how you have all these attachment points from the 5th all the way to the 12th ribs, and then they attach, they go forward and attach, are arranged in an oblique line which runs inferiorly and anteriorly, like you're putting your hands in your pockets, that kind of angle. And with the upper digitations being attached close to the cartilages of these close ribs, these digitations are arranged in an oblique line as well, which run inferiorly and anteriorly. The 5 superior serrations increase in size from above downward and are received between corresponding processes of the serratus anterior muscle, serratus anterior. The 3 lower ones diminish in size from above downward and receive between them corresponding processes from the latissimus dorsi. So what's important to know about that is that just remember that they go down and attach to this aponeurosis up front, and it stops at the linea alba up front, and it forms the inguinal ligament, which I told you earlier, which is right down and through here, the inguinal ligament. And the muscle also contributes, actually folds one of those aponeurosis actually folds backwards onto itself, forming an inguinal canal. And just to the external oblique is the internal oblique muscle, which is right here. This is your internal oblique. We'll go back a slide, spend a little bit of time. As you can see, the internal oblique is right in through here. Okay, it's the second layer. And actually, when you're sticking an acupuncture needle in and around there, so we used to have to know the fascia. So you're going to go through the dermis. Then you're going to have a fatty layer called the Camper fascia, and then the Scarpa fascia. Then you're going to have to go through another fascia. Actually the external oblique goes through there. Then it goes into the internal oblique, then the transverse abdominis. So there's 3 layers of muscle there. So these are really good points to utilize. And be careful with females because this one isn't too developed down and through here. And but really, all this area is safe right in through here. There's going to be some points in the CNT manual that might give you some warnings about femoral and arteries and bleeding stuff down and through the inguinal area. But for the most part, all this area is very safe to use. And so those are your external, internal obliques. Let's get a little bit more meat on the internal obliques. We're going to talk about what their function is and what they do. And their fibers actually run perpendicular to the external oblique. So there are different angles. It's important to know. And it's beginning in the thoracolumbar fascia, the lower back, the anterior 2/3 of the iliac crest. So I'll show you a picture of that. So as you can see right in here, the lumbar fascia as they form. So initially they kind of go up, and then the fibers start to run almost just like the transverse abdominis. So they kind of form in there and attach to this aponeurosis right in here, and then they help in forming inguinal canal as well, as you can see. All right, and so yeah, so the muscle fibers run from these points superior medially up and towards the midline to the muscles insertions on the inferior borders through the 10th through the 12th ribs and the linea alba, which is right up front. Okay, 10th through 12th ribs, and then the linea alba. So in males, right, there's a, for this internal oblique, is associated with the cremaster muscle, is also attached to the internal oblique as well. Okay, and that cremaster muscle is, there's actually cremaster reflex that they test babies to see if everything's intact down there. It's a, sometimes people have a overactive cremastic muscle. They have a cremaster reflex where they can actually, there's innervated down on the inner thigh. They use a tongue depressor or some type of object to stimulate that in babies, and you can see the testicles like going really fast. It's called a cremastic reflex. But an overactive cremastic reflex is indicative of actually testicles that don't actually sit in place right. You know, they actually haven't dropped yet. So they could, there's also some problems with that we can get into later and discuss. You know, the reproductive system. But there you have it. That's the internal oblique. Then the transversus abdominis is also known as the transversalis muscle, is a muscle layer of the anterior and lateral front and side of the abdominal wall, which is deep to the internal oblique, right? So it's deeper than this one. Go back a couple. So you see it's the final, it's kind of the last layer, right? From your transverse, you go exterior to that, you have your internal, and exterior to that, you have your external oblique that we already talked about. See the angle, it's kind of straight in towards the rectus sheath and the linea alba. And of course, you have your rectus abdominal muscles right in through here. We're talking mainly about your oblique muscles before you hit the rectus abdominis. So we're talking about these three right in through here. So just understand that, you know, it's at its lowest, the deepest layer. And we'll discuss the linea alba. I've already talked about the Wren line. Just remember, it's a fibrous structure that runs down the midline of the abdomen. And in humans, the linea alba runs from the xiphoid process right here, which is attached to the bottom of the sternum, all the way down to the pubic symphysis, right down there, part of the pelvis, right? And the name means white line, and the linea alba is indeed white. When you open someone up, it is white. And being composed of mainly collagen connective tissue. And it is formed by the fusion of the aponeurosis of the muscles of the anterior abdominal wall, and it separates the left and right rectus abdominal muscles right here. What else can we say about the linea alba? In muscular individuals, its presence can be seen on the skin, forming the depression, right? That six-pack ab or eight-pack ab, whatever. Yeah, it's called the six-pack, right? Because it consists of mostly connective tissue and does not contain primary nerves or blood vessels. A median incision through the linea alba is a common surgical approach, but oftentimes, because there are some inner nerves deeper into there, some surgeons will elect to cut on the side because this doesn't always heal up right. If it doesn't match perfectly, people will tend to have a tendency to have herniations from these areas later after surgery. So oftentimes they'll cut, if they need to access this area, they'll cut through these sheaths of the rectus abdominis just to the right or left side to gain access. So, yeah. All right. Okay, so working down, what you're looking at here is if you were at the head of the table and someone was cut in half and right above the pelvis, and you were looking down from where the head was down, through the body, through the pelvic cavity here, you're going to have a group of muscles here that are really important as well. They help with a lot of different aspects of both digestion and reproductive area. So earlier on last slides, we talked about the symphysis pubis, where that's where that linea alba attaches to, in this cartilage area right in here. This is the inguinal canal that runs down through those external, internal oblique muscles, and they all form that inguinal canal that runs both sides. Okay, so now you get the picture, get the orientation, what we're looking at. So here's your spinal column. Here's your spinous process of one of the vertebra, and here is your vertebra, right? So you're looking at your yeah. So you're looking at the big pelvis area right in through here. And we'll go ahead and start discussing the muscles, aspects of the levator ani. So the levator ani is a broad, thin muscle group, right? So you can see right here, it's composed of two different muscles. Actually, there's three. There's actually obturator internus we'll discuss as well. But it's composed of the pubococcygeus, the iliococcygeus, and the puborectalis. Okay, the puborectalis you can't see here, but we'll discuss the obturator internus as well. So is it attached to the inner surface of each side of the lesser pelvis. So right in through here, right? And these unite to form the greater part of the pelvic floor, which is very important, right? The coccygeus muscle completes the pelvic floor, which is also called the pelvic diaphragm. So you can consider this whole sheath here a pelvic diaphragm of muscle tissue. It supports the viscera, the pelvic cavity, and surrounds the various structures that pass through it, to include some of your digestion issues and all of these kind of things. So you have your genital diaphragm, your vagina, and your anal canal lies behind it. So it supports a lot of that and offers all that area integrity, holds things in place. And the levator ani, right, is the main pelvic floor muscle. And this is the muscle that painfully contracts. It is also, it also contracts, during vaginismus, which is yeah, it actually contracts during different times of orgasm and childbirth and these kind of things. So that's what that does there. The coccygeus is a muscle of the pelvic floor, and it's located posterior to the levator ani. Let's see if I can get you a picture of it. Yeah, so the coccygeus lies posterior, right, to the levator ani. The levator ani is here, coccygeus is here, right? So it lies posterior to it. It is a triangular plane of muscular and tendinous fibers. arising by its apex from the spine of the ischium and the sacrospinous ligament. So right in through here, right? And uh, its base into the margin of the coccyx, right? So here's your coccyx right in through there, and into the side of the lowest piece of the sacrum, and right in through here. In combination with the levator ani, it forms the pelvic diaphragm. So those are the strongest muscles down and through there, the main ones that you should remember. It assists the levator ani and the piriformis muscle in closing in the back part of the outlet of the pelvis. So your piriformis muscle, which is often treated, we actually do muscular skeletal testing with this piriformis muscle that we can talk about later and get into muscular skeletal testing and surface anatomy. We'll be able to show you a couple of stretches there. We test because piriformis syndrome is also differentiated from sciatica, and sometimes you get a lot of the same symptoms and comes from the same nerve root. So we'll discuss that as well. Okay, getting into the pec minor, we discussed this muscle before. It arises from the upper margins and outer surfaces of the third, fourth, and fifth ribs. So we should be really familiar with this, right? Here's your subclavius, which runs underneath the clavicle, but your pec minor is right in through here, all right? So you guys did an assignment on it, so you should be very, very familiar with it. Get used to it. So that's your pec minor, right? It's basically these big muscular tissue that runs down part of the sits muscles. As you can see, there are attachment points on the different ribs. Isn't it unique how these muscles, you just never know where where they're, what they're for and how they were designed. But as you can see, they all have really cool mechanical advantages. And so these fibers run, they run superior and lateral and converge to form a flat tendon, which is inserted into the medial border and upper surface of the coracoid process of the scapula, which is up and through there, all right? So its main function is for scap depression, but it's also one of the sits muscles, right? So the pec minor depresses the point of the shoulder, drawing the scapula superior, all right, towards the thorax and throwing its inferior angle posteriorly. So that's what that pec minor for. It's also one of the shoulder muscles, hold things together, right? So that's what we have to say about that. So the serratus anterior, get down to that, is a muscle that originates on the surface of the first to the eighth ribs. As you can see, first through eighth rib, and at the side of the chest, and inserts along the entire anterior length of the medial border of the scapula. So looks like they pulled it back slightly. As you can see, most of the muscle fibers converge at the inferior angle of the scapula. So what's it do? What's this muscle do? It actually protracts the scapular and upward rotation of the scapula. And it actually, the serratus anterior muscle acts to pull the scapula forward around the thorax. And what is it named? If you look at serrar, is to saw, referring to the shape, and it looks like a saw. And anterior, of course, is on the front side of the body, moving towards the front side of the body. So that's your serratus anterior. So just remember that these muscles and combine together, pull the scapula forward and around the thorax, which is essential for antiversion of the arm. So there involves the shoulder, right? And that whole area is very complicated. Muscles move at different angles and attach at different points to form, to help you with a bunch of different activities with the scapula and the shoulder. As such, the muscle is an antagonist to the rhomboids. However, when the inferior and superior parts act together, they keep the scapula pressed against the thorax together. So they, just depending on if they're working unilaterally or together, they have different functions. And so with the rhomboids, these parts also act as synergists to the rhomboids. The inferior part can pull the lower end of the scapula laterally, so this lower part, and forward, and thus rotates the scapula to make elevation of the arm possible. And additionally, all three parts can lift the ribs when the shoulder girdle is actually fixed, and thus assist in respiration. The serratus anterior is occasionally called the big swing muscle or boxer's muscle because it's largely responsible for the protraction of the scapula, and that is pulling of the scapula forward and around the rib cage that occurs when someone throws a punch. So the serratus anterior also plays an important role in the upward rotation of the scapula, such as when lifting a weight overhead. It performs this in sync with the upper and lower fibers of the trapezius. And so, very interesting muscle. And let's get on to the next one. So here's a picture of a winged scapula. So this is indicative of a damaged serratus anterior muscle we just went over. And muscles that cause the deformation of the back, and the serratus anterior muscle attaches to the medial anterior aspect of the scapula, as we discussed, and it attaches to the side closest to the spine and runs along the side of the scapula that faces the rib cage, and normally anchors the scapula against the rib cage. But when the serratus anterior contracts, upward rotation, abduction, and weak elevation of scapula occurs, allowing the arm to be raised, right? So when this is damaged, you'll have some type of winged aspect. There's a test you can do, have the patient put the hands up against the wall, bare the back, and you'll see one side that's pronounced, the other one looks normal. That's called a winged scapula. So it could be a nerve issue, or it could be damaged muscles. So here we have the trapezius muscle. So the upper part of the trapezius, right? The upward fibers, that actually helps with scapula elevation. The middle aspect, right here, the middle fibers actually do retraction, so it retracts it in, and the lower aspect does scap depression. So when you mix these two contractions together, like the upper and lower, it equals scap rotation, right? Scapular upward rotation. So, that scapula can move around a lot. These muscles help out, the trapezius as well. A lot of great acupuncture points in through here. So, the origin is the head and neck and the thoracic vertebra, right? And we'll discuss, a little bit more about it. So let's talk a little bit about the origin, insertion, and action of the trapezius. So as you can see, you have a nuchal line right here on the back that we discussed a few weeks ago. So you have a nuchal line, you have all these attachment points here. So it's the middle third of the superior nuchal line and the external occipital protuberance. There's also ligamentum nuchae in there, and the spinous processes from C7, right, from C7 all the way down to T12. So all these attachment points, that really covers a lot of the cervical spine and all the way down to T12. Interesting, right? And then you have this mechanical advantage, the upper fibers, middle fibers, and lower fibers. So it connects to the lateral third of the clavicle, the medial side of the acromion, so the acromion process out here, and the upper crest of the scapular spine, right in through here, and the tubercle of the scapular spine. So yeah, right in through here. I think it's a pretty unique muscle because it has so many different varieties of attachment points, which offers a lot of unique characteristics and unique functions. So remember, it elevates and depresses the scapula, right? And depending on which part of the muscle it contracts, it rotates the scapula superiorly and retracts the scapula. It's named for its shape. Trapezius is an example of a muscle that migrates during development from its level of origin, cervical, to its final position, pulling its nerve and artery along behind. Interesting muscle. Okay, we're going to talk about the trapezius. The origin is the middle third of the superior nuchal line. Okay, and the external occipital protuberance and the ligamentum nuchae and the spinous process of the cervical, the vertebrae C7 through T12. All right, that's the front side of it. Right, so you can get a better picture of it. And just remember what the actions are of that, and where it's at. Definitely the location. Here's the acromion process. That wasn't too good of a picture the last time I showed it. And here's another picture that I found. We talked about how the serratus anterior and the trapezius act together to rotate the scapula. So you have your upper fibers of the trapezius lifting the scapula in this direction, and the lower fibers of the trapezius and the lower fibers of the serratus anterior working together synergistically to actually lower and pull the scapula down. So very unique. There's a lot of, when I went through shiatsu training, there's a lot of work around the scapula and stretching and rotating, and now the scapula, you'll get a lot of points on the outer shoe, the outer urinary bladder, that form a lot of spiritual points right in here, the hun and the po, and they're utilized a lot to lower stress. So that's your medial border of the scapula. That's your outer UB line that runs parallel with the spinal column. You have your inner urinary bladder channel and your outer urinary bladder channel. And this is the medial border is kind of the borderline, a good benchmark for these points. All right, let's talk about the latissimus dorsi, right in through here. So the origin is the vertebral spines from T7 to the sacrum, all the way down to the sacrum. So your thoracic vertebra 7 all the way down to the sacrum. And the posterior third of the iliac crest. So in the lower 3 or 4 ribs, sometimes from the inferior angle of the scapula. So a lot of areas that it originates from, and it attaches to the floor of the intertubercular groove. The intertubercular groove. Yeah, so everyone asks, okay, what is the intertubercular groove? What is this you speak of? So it attaches to actually a portion of your humerus, which allows you, when you do lat pull downs, you're pulling down, right? So that lat muscle has to attach on the humerus to allow that anchor, to hold on to it so that you could actually pull, um, you can actually pull your arm down using that lat muscle. So I'm going to pull this down and show you what I'm talking about. Got a good picture of that groove. So here's some from some of my training here. Let me see what we got. Pull it down all the way. You see that? So it's actually a groove that's set on the back of the humerus, and you've got a lot of good tendinous tissues right in there. And there's some, deep embedded, uh, tissues in there to offer a lot of strength to that lat. And it's weird that a back muscle would attach, to the arm, but that's how it works. So we talked about the origin and how we can powerfully adduct. We can do medial rotation and extension, and also we can also do the scapula downward rotation using that lat. All right, so a lot of cool functions and different mechanical advantages for that. So we'll pull that out of the way. That's your latissimus dorsi, um, and that's what we have. So I do want you guys to remember on this muscle the action, and I also want you to remember the origin and insertion of this lat muscle. So it's also, so just go ahead and review it real quickly with you. So it's responsible for extension, adduction, transverse extension, also known as horizontal abduction, flexion from an extended position, and medial internal rotation of the shoulder joint. It also has a synergistic role in extension and lateral flexion of the lumbar spine. So if you go to that sheet that I offered in resources, it's through another college. It's really good resources to look at that. The information in there is the only information that I'll hold you accountable for, since I put it down on resources. So basically use that as a guide for your test questions. If I tell you on a slide that you're responsible for learning the origin, insertion, and action of this muscle, this is one of the muscles I want you to do. I want you to get used to, seeing this muscle, and by looking at the fiber directions, determining what the muscle actually can do, what's its function. So if you do enough of this all the time, if you get in practice, it's perishable too. If you don't use it often, you lose it. So I mean, you could go through an anatomy course last year, and then you have to kind of review every time. It's a lot of information. But if you can take a look and see where its attachment points are on this muscle and then the lat, you can't really see its attachment point here. But if you saw the attachment point on the arm, you can kind of deduct that if this muscle pulls in this direction and contracts, it's going to allow this arm as a good lever if it attaches to the upper part of the humerus, deeply embedded into that groove. It's going to pull that arm down, right? So, yeah, there you have it. Let's get on to the levator scapula. So we're going to talk about the levator scapula, and we're going to talk about the rhomboids. And the rhomboids have a rhomboid minor and a rhomboid major. So let's talk about the levator scapula. So the levator scapula is a muscle situated at the back and side of the neck that a Latin name suggests its main function is to lift the scapula, levator scapula. So the levator scapula originates from the posterior tubercle of the transverse process of the cervical vertebra 1 to 4. And the muscle is inserted into the medial border of the scapula. So there's your medial border. We talked about that at length. That's your marking point of the outer UB channel right in through there. And what else can we say about it? It's extending from the superior angle to the junction of the spine and medial border of the scapula. So great muscle. And levator scapula may lie deep to the sternocleidomastoid at its origin and deep or adjacent to the splenius capitis right in through there at its origin and mid portion and deep to the trapezius in its lower portion. Okay, so great muscle. What can we say about it? Okay, so what can we say about this muscle, levator, the trapezius, right? Pardon me. Okay, so just a quick rehack of the levator scapula. Understand where the origin is and the attachment points. Remember that it elevates the scapula. That's all I want you to remember about that. It's named for its action. So there you have it. Okay, so we discussed the levator scap. Let's get down to the rhomboid minor and the rhomboid major. So the smallest of the rhomboids is the minor. So remember, people get these mixed up. So remember, the smallest is the minor, and it sits up top, and the rhomboid major is on the bottom. So if you see this on an identification question on your midterm, understand that it's the largest portion, right? The rhomboid major. So let's discuss the rhomboid minor first. Its origin is the inferior end of the ligamentum nuchae and the spines of the vertebrae of C7 and T1. So there's your C7 and T1 vertebra, right? And the medial border again, right in through there, okay? Medial border. So just like the levator scap is a medial border, it just angles off slightly. But you have your medial border as a lot of these different attachment points. Great acupuncture points right up and through there. So that's the medial border of the scapula at the root of the spine of the scapula, right? That's your minor. What's it do? It retracts, elevates, and rotates the scapula inferiorly. So, I mean, if you can see that, it makes sense, right? So you see a band of muscle, so if it contracts, you can rotate that scapula, inwards like this, right? So inferiorly, right? So it'll rotate it inferiorly. Just as that mechanical advantage, you have a higher attachment point and a lower attachment point. So if it contracts, it's gonna pull it, right? And it's named also for its shape, right? Rhomboidal. So let's discuss the rhomboid major down below. It's this muscle here, also attaching to the same medial border of the scapula. Its origin is the inferior end of the ligamentum nuchae, spines of the vertebra C7, right? C7 through T1, right? Pardon me, T2 through T5. I'm sorry. So this is this is C7 up here. That's the minor. The major is actually down here, and that's going to be T2 through T5. And you have to remember the origin. The insertion You're going to see on a test question, you're going to see, these muscles all attached to the medial border. As far as the wording is concerned, it'll probably just say medial border, okay? And it's not going to give you all these, fancy terms, but that resource I gave you will give you a pretty good idea. And understand that what it does. It also retracts and elevates and rotates the scapula inferiorly. So it does the same thing. For some reason, our creator decided to separate it right there. So that's it for the levator scap and the rhomboids. They all have a common attachment point, the medial border of the scapula. So this is what we discussed for muscles 1. We talked about the structures of skeletal muscles, the muscle shapes, muscle roles, and the arrangement of these skeletal muscles. We also discussed contracting types. This is going to be a short quiz for you guys, probably do like 5 or 6, 7 questions, and to prepare you for midterm. And we talked about the nomenclature and the major skeletal muscles. And we're going to also get into this week, some other muscles down the lower half of the body. And we're going to get into some other accessory type muscles. So I hope you learned a lot, from this. It's a lot of work, I understand, but we'll keep at it, and by the time you guys get done with this, you'll have a pretty good solid foundation to start your acupuncture training and get into point selection and describing these different points in the muscles. So I'll go ahead and finish this off and send it off. And to review your quiz, I just wanted to touch on that. So I have both the axial and appendicular slide presentations under resources. You open those up, work through those real quick, and especially the one, I believe it was, in the 20s, 26, 27, they're both the same one, somewhere around there. But just take a look at the scapula and look at the different angles. And all it's doing is it's turning over the scapula, and you have to describe the same points. Okay. So no trick question. I won't do that to you on the midterm, but I want you guys to get used to the training tool to look at, even the clavicle from different angles. If you rotate it, can you still describe it, or can you just describe it at one angle? So get used to, looking at the bones at different angles. All right, that's all I have, and we'll see you guys on Friday.